pain, temperature, sleep, and sensory function. Pain is a complex, protective phenomenon that is unique to each individual. It cannot be objectively measured by an observer. As nurse theorist McCaffrey stated, pain is whatever the experiencing person says it is, existing whenever they say it does. Pain serves as a warning system that mobilizes us to react to injury or threat. The process of sensing harmful stimuli is called nociception. It begins with nociceptors, which are free nerve endings found in the skin, muscles, joints, arteries, and internal organs. These receptors detect mechanical, thermal, and chemical stimuli. Fast, localized pain is transmitted by A delta fibers, while slow, dull pain travels via unmyelinated C fibers. This may show the anatomy of pain pathways, highlighting where nociceptors send signals and how the spinal cord relays them upward. Understanding the different types of fibers and pathways is essential for targeting pain management therapies. There are 4 phases of nociception: transduction, where nociceptors are activated; transmission, where impulses travel to the spinal cord; perception, which is the conscious experience of pain; and modulation, where the brain and spinal cord increase or decrease pain signals. Pain is shaped by sensory, emotional, and cognitive systems and varies from person to person. Neurotransmitters modulate pain at multiple levels: peripheral nerves, the spinal cord, and the brain. Excitatory neurotransmitters like glutamate, substance P, and calcitonin gene-related peptide enhance pain transmission. In contrast, inhibitory neurotransmitters like GABA, serotonin, glycine, and norepinephrine help dampen the pain response. Endogenous opioids are naturally occurring substances in the body that inhibit pain. They are similar in structure and function to morphine. These opioids bind to specific receptors in the brain, spinal cord, and periphery, helping to reduce pain perception and enhance a sense of well-being. Several types of endogenous opioids exist. Enkephalins are the most abundant. Others include endorphins, dynorphins, and endomorphins. All of these bind to opioid receptors and produce effects similar to pharmacologic opioids, such as analgesia and euphoria. Endocannabinoids, derived from phospholipids, act as another form of natural pain control. They are chemically similar to cannabinoids found in cannabis and produce analgesic effects in humans. However, their clinical use is limited due to psychoactive and addictive properties. Pain modulation involves descending inhibitory pathways that use opioid receptors to suppress excitatory neurotransmitter release. Inhibitory neurotransmitters like serotonin and norepinephrine are also involved. Another mechanism is segmental inhibition, where stimulation of non-painful A-beta fibers reduces pain signals. These systems provide the basis for techniques like massage and transcutaneous electrical stimulation. Diffuse noxious inhibitory control, or DNIC, is a phenomenon where pain is reduced when a second painful stimulus is applied at a different body site. The placebo effect is another form of modulation, where cognitive expectations can activate brain regions that suppress pain. These concepts highlight the brain's powerful role in altering pain perception. Acute pain is a protective mechanism that alerts the body to potential harm. It begins suddenly and typically resolves once the underlying cause is removed. This type of pain mobilizes an individual to take immediate action and avoid further injury. Though unpleasant, it serves a vital biologic purpose. Somatic pain comes from the skin, joints, and muscles and can be sharp or dull. Visceral pain, on the other hand, originates in internal organs and the linings of body cavities. Visceral pain is often poorly localized and described as throbbing, aching, or cramping. It frequently radiates or is referred to other areas of the body. Referred pain is pain perceived at a location other than the site of the injury. This occurs because different body areas are innervated by the same spinal segment. For example, pain from a heart attack may be felt in the jaw, neck, or left arm. Referred pain can be either acute or chronic. Understanding referred pain is essential for accurate diagnosis. Clinicians use knowledge of spinal nerve mapping to trace the true source of pain, even when symptoms are distant from the origin. This concept is critical in emergency and internal medicine. Chronic pain persists beyond the expected period of healing, typically lasting more than 3 to 6 months. It may be constant or intermittent and is often less about injury and more about how the nervous system processes pain. Chronic pain is associated with stress and produces psychological and behavioral changes. The body can adapt to ongoing pain, making it more difficult to treat. Neuropathic pain is caused by damage or dysfunction in the nervous system. It results in long-term changes in pain pathway structure and abnormal processing of sensory input. The pain is often described as burning, shooting, or shock-like. It can be classified as peripheral or central, depending on where the damage occurs. The body regulates temperature through heat production, conservation, and loss. Body temperature varies based on location, activity level, environment, circadian rhythm, and gender. This dynamic process helps maintain homeostasis and protects the body from extremes. Temperature regulation is controlled by the hypothalamus and influenced by the endocrine system. Peripheral thermoreceptors in the skin and organs detect external temperatures, while central thermoreceptors in the hypothalamus and spinal cord monitor internal conditions. This information is integrated to maintain a stable core temperature. The body generates heat through metabolism, muscle contraction, and chemical thermogenesis. It conserves heat via vasoconstriction, shivering, and voluntary behaviors like adding layers of clothing. These mechanisms work automatically and behaviorally to maintain thermal balance. Heat is lost through radiation, conduction, convection, evaporation, and vasodilation. Additional losses occur through increased breathing, decreased muscle tone, and conscious cooling behaviors. Over time, people can adapt to warmer climates, enhancing their ability to regulate temperature. Infants produce enough heat but have difficulty conserving it. Their small body size and high surface area to weight ratio make heat loss rapid. Additionally, infants have a thin layer of subcutaneous fat and cannot shiver effectively. Their heat regulation largely depends on increasing blood flow to the skin and behavioral responses. In the elderly, temperature regulation declines significantly. They often have slower blood circulation, reduced skin elasticity, and decreased shivering and sweating responses. Metabolic activity also slows with age, diminishing the ability to produce heat. These changes make older adults more vulnerable to both heat and cold stress. Fever is a temporary resetting of the hypothalamic thermostat to a higher temperature. It results from exposure to exogenous pyrogens like pathogens, or endogenous pyrogens produced by the body's immune response. The body reacts by generating and conserving more heat, making the person feel cold even as their core temperature rises. A fever of unknown origin is a prolonged high fever without an identified cause. The visual may show stages of fever development or the role of cytokines. Fever involves complex interactions between the immune cells, chemical messengers, and the brain. It represents an important part of the body's natural defense system against infection. Fever enhances the immune response in several ways. It kills many microorganisms, lowers blood levels of iron, zinc, and copper, minerals that pathogens need to grow. Fever also promotes lysosomal breakdown, increases lymphocyte activation, boosts phagocyte mobility, and stimulates the production of antiviral interferons. Overall, fever helps the body fight infections more effectively. Hyperthermia occurs when body temperature rises without an increase in the hypothalamic set point. It can cause nerve damage, coagulation of proteins, and even death. Hyperthermia may occur after stroke or brain trauma. In controlled settings, therapeutic hyperthermia can be used to destroy tumors or enhance certain medical treatments. Accidental hyperthermia includes several conditions. Heat cramps involve painful muscle spasms after heavy sweating and sodium loss. Heat exhaustion results from prolonged high environmental temperatures, causing profuse sweating and vasodilation. Heat stroke is a life-threatening failure of heat loss mechanisms, with core temperatures exceeding 40 degrees Celsius. Malignant hyperthermia is a rare, inherited disorder triggered by certain anesthetics, causing uncontrolled muscle contraction and high fever. Hypothermia occurs when body temperature drops below 35 degrees Celsius, or 95 degrees Fahrenheit. It slows nervous system and respiratory functions and alters coagulation pathways, leading to ischemic tissue damage. In severe cases, ice crystals can form inside cells, rupturing them and causing irreversible injury. Tissue hypothermia slows metabolism, thickens the blood, and triggers vasoconstriction. Therapeutic hypothermia is sometimes used to slow metabolism during surgeries or after cardiac arrest. However, accidental hypothermia, from immersion in cold water or prolonged exposure, can quickly become fatal if not promptly addressed. Traumatic injuries often disrupt normal temperature regulation. Central nervous system trauma can cause central fever, which is resistant to antipyretic therapy and lacks sweating. Other causes include accidental injuries, hemorrhagic shock, major surgeries, and severe burns. Managing body temperature is critical in trauma care to prevent further complications. Sleep is an active, restorative process that supports physical and cognitive function. It is regulated by the hypothalamus, which acts as the body's sleep center. Chemicals called hypocretins, or orexins, promote both wakefulness and REM sleep. Sleep occurs in two main phases: non-rapid eye movement and rapid eye movement. REM sleep makes up about 20 to 25% of total sleep and begins 90 minutes after sleep onset. Known as paradoxical sleep, REM has brain activity that resembles wakefulness. During REM, there is muscle relaxation, vivid dreaming, and a loss of thermoregulation. Heart rate, blood pressure, and breathing fluctuate, and parasympathetic activity predominates. NREM sleep accounts for 75 to 80% of total sleep time and is characterized by reduced brain activity. During NREM, sympathetic tone decreases while parasympathetic activity increases. This stage lowers metabolic rate, body temperature, respiration, heart rate, and blood pressure. It is critical for physical restoration and immune function. Sleep disorders are categorized into 6 major classifications. First, insomnia, which involves difficulty falling or staying asleep. Second, sleep-related breathing disorders, like sleep apnea, which disrupt normal breathing during sleep. Third, central disorders of hypersomnolence, such as narcolepsy, lead to excessive daytime sleepiness. Fourth, circadian rhythm sleep-wake disorders involve misalignment between the body's internal clock and external environment. Fifth, parasomnias include unusual behaviors like sleepwalking or night terrors. Finally, sleep-related movement disorders affect physical motion during sleep, such as restless leg syndrome. Dysomnias refer to difficulties in falling or staying asleep, leading to daytime fatigue and impaired function. They can range from mild to severe and may be acute or chronic. Common examples include obstructive sleep apnea, hypersomnia, narcolepsy, and circadian rhythm disorders. Identifying the type of dysomnia is key to effective treatment. Obstructive sleep apnea syndrome (OSAS) is the most commonly diagnosed sleep disorder. It's caused by partial or complete upper airway obstruction during sleep. Risk factors include obesity, male sex, aging, and postmenopausal status. Loud snoring, gasping, and episodes of apnea lasting 10 seconds or more are hallmark features. OSAS fragments total sleep time, leading to hypercapnia and low oxygen saturation. If untreated, it may cause hypertension, heart failure, dysrhythmias, and stroke. It can also result in hypersomnia, excessive daytime sleepiness, and impaired mood or cognition. Diagnosis is confirmed with polysomnography or sleep studies. Narcolepsy is a primary hypersomnia disorder marked by disruptions in the sleep-wake cycle. Symptoms include excessive daytime sleepiness, hallucinations, sleep paralysis, and sometimes cataplexy, sudden loss of muscle tone. It is often linked to autoimmune destruction of hypocretin-producing neurons in the hypothalamus. These disorders result from misalignment between the body's internal clock and external environment. Extrinsic causes include jet lag, rotating work shifts, or inconsistent sleep schedules. Intrinsic causes include advanced or delayed sleep phase syndromes. Chronic circadian disruption may lead to long-term health issues, including mood disorders and metabolic changes. Parasomnias involve unusual behaviors during NREM stage 3 sleep, often occurring without conscious awareness. These may include sleepwalking, night terrors, sleep-related eating, or even violent outbursts. Other examples include sleep sex and restless leg syndrome. These conditions can cause injury, fatigue, and social or psychological stress. The special senses include vision, hearing, olfaction, smell, and taste. These senses rely on specialized organs and are closely linked to cranial nerves. Vision is processed through the eyes, hearing through the ears, olfaction through cranial nerves I and V, and taste through cranial nerves 7 and IX. Together, these senses help us interpret and respond to our environment. The eye is composed of 3 primary layers. The sclera is the tough, white outer layer that becomes transparent at the cornea. The choroid is the pigmented middle layer that nourishes the retina. The retina is the innermost layer and contains photoreceptors, rods and cones, which detect light and color. Light entering the eye is focused by the lens, a flexible, biconcave structure that adjusts to different distances through a process called accommodation. The anterior chamber contains aqueous humor, while the vitreous chamber is filled with vitreous humor, helping maintain the eye's shape. The optic nerve carries visual signals to the brain. You may see labeled structures such as the iris, lens, and retina. Understanding the anatomy of the eye is essential for identifying visual disorders and guiding clinical assessments of vision. Alterations in eye movement can impair vision. Strabismus involves misalignment of the eyes. Amblyopia refers to reduced vision in one eye despite normal structure. Diplopia, or double vision, and nystagmus, an involuntary rhythmic movement of the eyes, are common. Paralysis of extraocular muscles can lead to symptoms like ptosis or restricted movement. Visual acuity is the ability to see fine detail. Disorders include amblyopia, scotoma blind spots, cataracts, papilledema, and glaucoma, an increase in intraocular pressure. Other conditions include retinal detachment, dark adaptation problems, and age-related macular degeneration, which leads to central vision loss. Accommodation is the lens's ability to change shape to focus on near or far objects. Changes in the oculomotor nerve can disrupt this process, resulting in diplopia, blurred vision, or headache. Presbyopia, the age-related loss of accommodation, makes it harder to focus on close objects. Refractive errors are the most common visual impairments. These include myopia nearsightedness, hyperopia farsightedness, and astigmatism caused by uneven curvature of the cornea. Presbyopia may also occur with age. These conditions affect the eye's ability to properly focus light on the retina. Color vision can also be affected. Age-related yellowing of the lens reduces color sensitivity. Color blindness, often inherited through an X-linked trait, commonly affects red-green vision. Acquired color vision changes may occur due to disease or medication use. Neurologic disorders that affect the optic nerve, optic chiasm, or optic tract can cause partial or complete vision loss. Damage may result in hemianopia, or loss of vision in half the visual field. These defects are often seen in strokes, tumors, or demyelinating diseases like multiple sclerosis. Visual disruptions can result from trauma, infection, vascular disorders, or neurological damage. Conditions like optic neuritis, retinal artery occlusion, or tumors can all impair vision. Accurate diagnosis depends on a thorough understanding of ocular anatomy and associated neurological pathways. Common external eye conditions include blepharitis eyelid inflammation, hordeolum or stite infected eyelash follicle, and chalazion blocked oil gland. Entropion is the inward turning of the eyelid, which can irritate the eye. Conjunctivitis, or pink eye, may be bacterial, viral, or allergic. Severe forms, like trachoma or keratitis, can threaten vision if untreated. The ear has three main parts. The external ear includes the pinna and auditory canal, which funnel sound waves toward the tympanic membrane. The middle ear contains the tympanic cavity and three small bones, malleus, incus, and stapes, which amplify sound. The middle ear also connects to the throat via the eustachian tube, helping regulate pressure. The inner ear manages both hearing and balance. It contains the osseous labyrinth, filled with fluid called perilymph. The cochlea is responsible for hearing, while the vestibule and semicircular canals maintain equilibrium. The organ of Corti contains hair cells that convert sound vibrations into neural signals. You may see labeled structures such as the cochlea, vestibular system, and cranial nerve 8. These structures must work together precisely to detect sound, interpret volume and pitch, and maintain balance. Disorders of the inner ear can affect both hearing and spatial orientation. Additional labeling likely includes the auditory ossicles, tympanic membrane, and eustachian tube. Understanding this anatomy is crucial for identifying the source of hearing loss or balance dysfunction, especially in pediatric or geriatric populations. Hearing loss may be conductive or sensorineural. Conductive hearing loss occurs when sound cannot travel through the outer or middle ear, often due to wax buildup, fluid, or bone issues. Sensorineural hearing loss is caused by damage to the organ of Corti, the auditory nerve, or its central pathways. Age-related hearing loss is called presbycusis. Mixed hearing loss includes both conductive and sensorineural components. Functional hearing loss refers to cases where no anatomical cause is found and the individual may appear unresponsive. Meyer disease is a disorder of the inner ear that involves excessive fluid pressure and causes vertigo, tinnitus, and fluctuating hearing loss. Otitis externa, or swimmer's ear, is an outer ear infection typically caused by bacteria and prolonged moisture exposure. Otitis media affects the middle ear and is more common in children. Acute otitis media causes pain, fever, and ear fullness, while otitis media with effusion results in fluid buildup without infection. Both can impact hearing and balance. The sense of smell is controlled by cranial nerve I and partially by cranial nerve V. Olfactory receptors detect airborne chemicals like musky, floral, or pungent odors. Smell is closely tied to taste and memory. Disorders in olfaction can impair nutrition, safety, and quality of life. The sensation of taste, or gustation, is primarily managed by cranial nerves 7 and IX. Taste receptors are located in the tongue, soft palate, pharynx, and upper esophagus. Humans detect 5 basic taste sensations: sour, sweet, salty, bitter, and umami, the savory flavor found in foods like cheese or soy sauce. Taste and smell work together to produce full flavor perception. Hyposmia refers to a reduced ability to smell, while anosmia is the complete loss of smell. Olfactory hallucinations are phantom odors sensed in the absence of a stimulus. Parosmia is a distortion in how odors are perceived, such as finding normally pleasant smells unpleasant. These conditions may result from trauma, infection, tumors, or neurodegenerative diseases. Hypogeusia is a diminished sense of taste, while ageusia is the complete loss. Dysgeusia is a distortion or perversion of taste, such as experiencing a metallic flavor. Taste dysfunction may result from chemotherapy, smoking, oral infections, zinc deficiency, or cranial nerve damage. These disorders can reduce appetite and affect nutrition. The somatosensory system allows us to sense touch, pressure, vibration, temperature, and pain. Specialized skin receptors like Meissner corpuscles, Pacinian corpuscles, Merkel discs, and Ruffini endings detect various stimuli. As people age, tactile discrimination declines, increasing the risk of injury or missed sensory cues. Proprioception is our sense of body position and movement. It relies on feedback from the inner ear, joints, and ligaments. With aging, proprioception often declines, contributing to increased fall risk. Dysfunction may cause vertigo, vestibular nystagmus, or balance disorders such as Meniere's disease. Peripheral neuropathies can also disrupt position awareness.